Honorable Chairman, Kazi Munjur Kadir, Professor Dr. A K Azad, and Dr. Firdaus, and Mr. Dr. Jahangir Alam. I am Professor A K Mostaque, now working in Gonoshastha Samajvitik Medical College in the Department of Surgery. Though this study was performed in Ahsania Mission Cancer and General Hospital. Also, I am working with other two important persons, Dr. A.M.M. Shariful Alam, you know, the clinical oncologist, Ahsania Mission Cancer Hospital, and another, Dr. Abdullah Al Mamun. Now he is working in UK. Our study was survival function of breast cancer patients having serial axillary lymph node dissection. This is a prospective study. Actually, I want to know what is survival function. It is the probability of an individual to be survived after a specific treatment. This is survival function. So we know in a current state, we usually perform about 70% of our breast cancer patient is in T1 and T2 stage. We know T1 means 2 or less, and T2 means greater than 2 to 5 centimeter. And they usually perform, remove the tumor with limited axillary sample. I want to say axillary sampling. Actually, we know it is a sentinel lymph node biopsy, not a dissection, mind it. And with the idea, Kenwaiter could say, it is due to the LN dissection does not contribute in the better prognosis. Has no, that is, it has no therapeutic value. Still, why we are focusing on lymph nodes? This is because they predict that lymph node staging may help the prediction of prognosis. Actually, we know in esophageal, gastroesophageal junction, gastric, and other intra-abdominal and intrathoracic adenocarcinomas, there is a wide field of resection of lymph nodes. Even in some cases, even in the gastroesophageal junction, they usually perform 3-field dissection. One within the abdomen, like that of the radical Z2 gastrectomy, and also the mediastinal and hilar lymph nodes, and also the supraclavicular lymph nodes, 3-field dissection, because they found that these extensive dissection extend the disease-free survival as well as overall survival of a patient. But in case of carcinoma breast, why this ideology changed, I don't know. Here, they have the conservative approach to the axillary lymph node. Ipsilateral axillary lymph node, they have conservative approach. In fact, counting the number of positive axillary lymph nodes only might not express true prognosis of breast cancer, because there is a problem. Because number of axillary lymph node has a wide variation. It may be as minimum as 5, as maximum as more than 30 lymph nodes. So only counting the positive lymph nodes is not enough, I think. And I have a confusion when we start this study. Then, as because of confusion, we try to search another parameters for prediction of prognosis of the breast cancer patient, and it was lymph node ratio, axillary lymph node ratio. That is, number of positive lymph node divided by total number of dissected axillary nodes, and this will give the LNR. This is, in short, we call it LNR, and we think that this could efficiently predict prognosis, because both the component, positive and total, both are included in the surgical procedure. This study compared survival function of pathological AN staging and LNR subgroups of disease-free survival time as well as overall survival time of a breast cancer patient. This prospective cohort study was conducted on 51 consecutive breast cancer patients admitted in the Hassania Mission Cancer and General Hospital, Uttara, Dhaka. Though now I am working in Ganashastha. And data was collected between August 2016 to December 2019, just at the beginning of COVID epidemics. We know the PNA pathological node staging, N0, N1, N2, and N3. And also, but you should remember that this subclassification, mentioning the number, has no statistical support. Only I don't know how they define N0 with 0, how they define N1 with 1 to 3 lymph nodes. I don't know. We don't find any here. But in LNR, it is classified, again, this LNR was supported by cutoff value of statistics. And it was low when the value is less than or equal to 0.2, intermediate risk when 0.21 to 0.65, and high risk. These three groups. One important thing, after processing the data, we found only 4 cases belongs to pathological node stage 3, only 4. In contrast, in high-risk group, we found 9 cases, more than double, 9 cases of high-risk group. Duration of follow-up, actually, this follow-up result is according to December 22. This is because at the December 22, after the follow-up, at that date, we observed death of all the high-risk LNR group within this time. For this reason, we make another new data and we calculate it. And median follow-up duration of overall survival was 52 months. Number of deaths out of 51 was 21, and it is 41% approximately. As a death distribution, again we see pathological entry, 3 deaths out of 4 at December 22. On the other hand, or high-risk LNR group, all 9, 7% death out of 9 patients. This is important finding at bird's eye view. Now, this is the survival function. Actually, we already mentioned that what do we do? We, from this graphic, it is a graphic representation done by SPSS 24 program automatically. It is generated automatically. So this is survival function, this is cumulative survival, and this is duration of survival. Here from, we observe all the 4, PN0, PN1, PN2, PN3. All the curves has a haphazard, arranged in haphazard manner, like a caput medusa, I should say. It is we cannot conclude anything. And in pairwise comparison, we observed that it was a log rank test, indicated no significant difference between any pair, N0 with N1, N0 with N2, N0 with N3, N1 with N2, N2 with N3. No one show any significant difference for determination of the survival. On the other hand, this is a very organized curve. We observe low and intermediate group curve is almost similar. On the other, there is a huge gap with the high-risk LNR. And we also observed, pairwise comparison also observed significant difference between low and high, intermediate and high group. and no significant difference between low and intermediate group LNR. So same is the case with the disease-free survival. Same, there is a vortex. And there is no significant difference with anyone. On the other hand, survival function of LNR, same as like that of the overall survival curves. And also, we observe highly significant difference. For p-value, low and high differences, for p-value is 0.00003. And among intermediate high, 0.0001. So it is clearly evident that pathological node staging is not an effective measure for predicting survivability or survivability of the patient. In conclusion, LNR subgroup is unique way of expression of the best and worst survival time with precise ideation. However, axillary lymph node dissection is mandatory. Without axillary lymph node dissection, it will not possible. So we have ample scope in our perspective. Pathological anesthetizing cannot predict disease-free survival and overall survival of breast cancer patient. Important thing I want to mention that this is a nano size research, only 51 cases. I think everyone should come forward to observe what is going on when we adopt pathological node staging and lymph node ratio staging. Consequently, pathological anesthesia of TNM classification for BC should incorporate LNR by adding number like this, number of positive divided by total number of lymph nodes. We propose revision of TNM classification of breast cancer. Thank you very much.